Okay, this is such a quiet group. They must be interested in policy issues. Good morning. I'm Susan LeLacheur, and just to announce to you all, this session is brought to you by the Physician Assistant Education Association. That's the Association of Educators for PA Students. There's some more seats up here, guys, in kind of the front middle here. PAEA is running sessions in this room today and tomorrow, and several sessions may be of particular interest to those of you who precept our students, like on how to get CME credit for that, and also things like how to become an educator, either come give a lecture or be a clinical educator or get involved with your local programs. And so I will delay no more, and we've got a lot to talk about in a short time. Dr. Vasco Kidd.
Well, thank you. I appreciate that. Hello, folks. How you guys doing today? You guys ready to learn healthcare policy? We're going to go through 7,000 pages of voluminous legislation in 45 minutes. Okay? So this is rapid fire. Okay? Give you a quick background. I have a baccalaureate degree of health science from Cal State Dominguez Hills. I have a master's in health professions education from Western University of Health Sciences, where I also completed my physician assistant education. I attended a postgraduate fellowship program in orthopedic surgery at Arrowhead Regional Medical Center, graduated from that in 2003. I have a master's degree in health policy, or master's degree in public health and healthcare management and health policy from UCLA, and I have a doctorate in health science from A.T. Still University. And I love education, but I'm coming to a point of diminishing return. And so the debt's starting to pile up. So I've decided to take a hiatus for a while. All right, folks, we're going to talk about healthcare reform, and I'm going to give you some objectives pretty quickly. At the conclusion of the spotlight participation, we're going to discuss the participants should be able to discuss the current healthcare statistics, discuss the implications of the Supreme Court decision on the Affordable Care Act, discuss the challenges with implementing the Affordable Care Act, discuss the costs associated with the Affordable Care Act, and then we're going to look at the California experience, because California is actually moving pretty rapidly in terms of implementing the Affordable Care Act, and then we're going to describe some embedded strategies to improve the primary care workforce, and again, all that in 45 minutes. All right, so let me just take a quick audience poll. Does the government have the right to force Americans to purchase insurance? Yes or no? Raise your hand. Now, that's a commercial product, right? Okay? Because healthcare is a good, like education is a good, housing is a good, food's a good, right? So does the government have the right to mandate or enforce people to purchase healthcare insurance? They have a right to do it with car insurance, right? Okay? Matter of fact, in the state of California, there's a mandate for car insurance, but yet 25% of Californians don't have car insurance, which is why we have uninsured driver. Do you believe that the healthcare reform will make Americans more healthier? Really? No, hey, I'm just playing devil's advocate here. So do you believe that healthcare reform will make Americans more healthier? Yes. Okay. Do you believe that the Affordable Care Act will reduce healthcare costs in the long run? You know, we've been having healthcare inflation. We've been looking at premiums skyrocketing about 130% over the last decade. So do you believe this is a good thing for America? Or is this just going to be another government-failed bureaucratic program? Yes. Okay, so all right. So people are vacillating back and forth. All right, good. All right, so this is what we've seen so far. This is the societal acrimony and the contentious debate that we've seen in healthcare reform. We have folks that are for healthcare reform and folks that are not for healthcare reform. Now, I'll give you my implicit bias. I'm a firm believer that healthcare is a right, but then when I say that, people say, well, then who pays for the rights of others? Now, remember, I'm an egalitarian, so being egalitarian, I believe in equity, and I believe that we should indeed, allow people to have healthcare so that they can benefit. It benefits society, whole, makes them more socially productive. But again, who pays for the rights of others? We're going to talk about that in a moment. So let's go through some sobering healthcare statistics. We pay 18% of our GDP is spent on healthcare. That's more than any other industrialized nation on the planet, okay? And we don't have universal healthcare coverage. That equates to nearly $3 trillion a year, which is larger than the gross domestic product of over 200 countries worldwide. So that's pretty significant. What we spend on healthcare is not even the budget for most countries, to be quite frank. There's 44,500 deaths attributed to a lack of healthcare insurance. People are dying prematurely because they can't manage their chronic conditions and comorbidities because they can't get in to see the doctor because they lack healthcare coverage. Now, that's not my anecdotal opinion. That's a research study put out by Harvard, okay? There's 78 million baby boomers getting ready to retire soon. Now, that's interesting because that means that Medicare spending is actually going to double. Does everyone know about Medicare, right? There's Medicare Part A that pays for hospital insurance, Medicare Part B that pays for outpatient services, Medicare Part C, which is mostly an HMO, and Medicare Part D, which is really prescription drug benefit, okay? The other interesting thing, and again, this is an interesting, $100 trillion in unfunded liabilities. That's Medicare, Medicaid, and Social Security. That's government statistics, ladies and gentlemen. Unfunded liabilities are promises that we made to our seniors that we have not yet fulfilled. So we're $100 trillion in debt, and we're running trillion-dollar year-over-year deficits, okay? So that's something to think about when you think about healthcare reform, because you have to understand the economic impact of healthcare reform as well prior to implementation. A family of four, if you're looking at a PPO plan now, a family of four for a PPO plan is $20,728 currently. That's up by 6.9% from last year. So even though we've had healthcare reform passed in 2010, why are healthcare costs continuing to rise? Because the whole point of healthcare reform was to contain costs, to improve quality, to improve coordination and access to care. Okay? Job-based family plan, which is essentially employer-based coverage, is now $15,000 annually. Now, let me just kind of put some skin on this for you. Okay? Starbucks actually was paying more for health care benefits for their retirees and current employees than their signature product, coffee, and GM was essentially paying more for health care for its retirees than they were for steel. Now, that's unsustainable in the large business community. Let's talk about the Affordable Care Act. Now, when you talk about the Affordable Care Act, really healthcare reform is made up of three parts. Student loan reform. Many of you might have benefited from that, or your students are benefiting from that. What we call the IBR, which is the Income-Based Repayment Plan, actually came out of the Affordable Care Act. The Class Act, which is long-term care insurance, and then also healthcare reform. Now, if you remember, the Class Act was actually repealed. Does anyone know who repealed that? The government did. The government repealed it because they couldn't pay for it. So remember, it's a three-part Class Act, long-term care insurance, because right now Medicaid is the primary payer of long-term care insurance in the United States. So the government tried to create another program that would supplement or subsidize long-term care insurance, but they had to repeal Class Act. So I know the House just recently repealed the Affordable Care Act. Of course, that hasn't, went to the Senate. I'm sure it would have gotten vetoed by President Obama. The Affordable Care Act was passed in 2010, as I said before. It was supported by the American Medical Association, Retired Persons Association, as well as most healthcare insurance industries. Let me ask you why. Why is the insurance companies benefiting from healthcare reform? Because there's more members coming into the system. There's more due-paying members, so I can spread the risk across a larger pool. If I'm going to have to take care of people with pre-existing conditions, I want more people paying into the system. Does that make sense? Okay? You don't want to start taking care of people with pre-existing conditions and you don't have any extra revenue coming in because it's going to affect your bottom line, okay, if you're an insurance company. 32 million people are slated to be covered by the Affordable Care Act. Now, the budget windows from 2010 to 2019. That's important to keep in mind. And the cost of the Affordable Care Act, when it was first introduced, was $940 billion. The CBO then came back and said, oops, we made an error. It's actually going to cost twice that amount, $1.76 trillion. And then there was uproar from the community, uproar from community groups, from folks in the House and also Democrats. And then they went back and said, oops, we made another mistake, and it's really going to be $1.2 trillion. When this is all said and done, it's probably going to cost us about $3 to $4 trillion to implement this thing across the board. And that's the facts. Okay, so let's see who's eligible for healthcare reform and who's not eligible. So incarcerated persons are not eligible, Indian tribes, people who object to purchase based on religious belief. So if you go, hey, my God said I don't need to purchase healthcare insurance, guess what? As long as you can get that certification from a healthcare exchange saying that you're exempt, you don't necessarily have to purchase healthcare insurance. Financial hardships, those who are unable to purchase the affordable insurance through an exchange, and these are people who essentially fall out of the federal poverty limits, and we're going to talk about that, and undocumented workers. Now let me say something about the last bulleted item there. Undocumented workers typically use the emergency room as a de facto primary care, right? But they also use federally qualified healthcare centers. There's billions of dollars that have been allocated from the Affordable Care Act to these federally qualified healthcare centers. So if you're an undocumented or someone who's here illegally, you can essentially show up, receive primary care services if you can prove residence, not citizenship, right? So that's the caveat, okay? So you can still get, so it's a back door to receiving some of the benefits for those who are undocumented, okay? Now, some of the other Affordable Care Act benefits, children now are covered up to 26 because now they're on their parents' insurance. Children with pre-existing conditions. You can no longer medically underwrite policies. Everyone knows what medical underwriting is, right? The ability to determine eligibility. or to disenroll someone based on a pre-existing condition. So you can't do that anymore for children, but you can still do that for adults, which is why we have high-risk pools. High-risk pools means that you really can't get covered by anybody else, but there is kind of another mechanism for you to get covered, but you have to pay higher premiums in a high-risk pool. By 2014, you can't exclude anybody, regardless of a pre-existing condition. Right now, you can because we're in 2013, except for children. Does that make sense to everyone? Okay. So there's also elimination on lifetime limits on essential health care benefits, which were typically capped at $1 million, but now it's extended. So what about the individual mandate? Do we still have the individual mandate? We recently had the Supreme Court decision. Remember that? And there was some issues about the constitutionality of the individual mandate, whether or not the government can force you to buy a commercial product. So the states, along with the small business community, took the government to court and said, well, it's really unconstitutional for you to force us to buy health care insurance. As a matter of fact, it's rather intrusive. Okay? We're not interested in you telling us what to do. It's kind of the whole concept of American exceptionalism, right? Okay? We do it the way we want to do it. We don't want to be told anything else, especially by government. Okay? I guess that's if you have the conservative approach. It's a little bit different. So do we have the individual mandate? The answer is yes. The Supreme Court upheld the individual mandate based on the fact that it's a tax. Okay, I want to make sure that we have a clear distinction there. The individual mandate, according to the administration, was being upheld by the Commerce Clause. The Commerce Clause regulates interstate commerce, okay? And it's also been used to fight racial segregation as well as domestic violence. So they used the Commerce Clause to try to pass off the individual mandate. The Supreme Court looked at it and said, well, it doesn't really apply to the Commerce Clause, but it does apply to Congress's ability to levy taxes. So since it has a penalty for noncompliance, it was upheld as a tax. Okay, so we have the individual mandate, but the individual mandate, according to the Supreme Court, is really a tax. Okay, so something to think about. Okay, now here's kind of the penalties associated with noncompliance. Okay, so in 2014, we're going to go down to the last column where it says 3+ adults. In 2014, if you do not have health care insurance, and by the way, the IRS is going to determine that. We're going to talk about that in a moment. It's going to be 1%, and the IRS has been in the news recently. There's going to be a lot of transparency. So 1% of your AGI, which is your adjusted gross income, which is essentially is $285. So it's really almost prohibitive to purchase health care insurance because I can rather pay the penalty versus paying an escalated premium over the course of 12 months. But we're going to see if that's really true or not. Okay, in 2015, it goes up to 2% AGI, or $975. And then, of course, in 2016, it goes to 2.5%, which is roughly $2,085. Now, there's also an employer mandate as well. The employers have to provide insurance for those who have 50 or more employees. Okay, so if you don't give insurance out to your employees, then you get fined $2,000 in forms of a penalty, and if your employee purchases insurance through a healthcare exchange, you get taxed on another $1,000. So it's a $3,000 penalty for employers whose employees go find insurance through a healthcare exchange. We're going to talk about that in a moment. Okay. And by the way, who's responsible for administering the penalty? Again, the IRS. Okay. So we're going to talk about Medicaid real quick because I think it's important because this is the primary mechanism in which the Affordable Care Act tries to bring most folks into the system. Okay? That in the individual market, but typically it's Medicaid. Now, everyone knows what countercyclical means, right? It's the ability of Medicaid to expand during recessionary periods, during tenuous economic environment, where, there's massive unemployment, there's issues with finding a job and so forth. So it really is what I call an insurance of last resort. So it's the ability to swell to take on new enrollees during financial hardships. Before, Medicaid was really an incomplete program. Unless you were pregnant or had dependents or had some type of disability, you didn't really qualify for Medicaid, even if you met a certain federal poverty level. Nowadays, according to the Affordable Care Act, there's a national floor of eligibility at 133% of the federal poverty level, which means that you don't have to qualify based on having dependents any longer. You qualify solely based upon income. Okay? So for an individual, at 133% of the federal poverty level, that's about $15,000 a year. For a family of 3 or 4, that's roughly about $30,000 a year. So now those folks would actually qualify, and they would qualify for a federal subsidy, which we'll talk about in a moment. Now remember, Medicaid program is essentially a joint effort between the state and the federal government. So there's 51 Medicaid programs if you include the District of Columbia. There's only one Medicare program, right? And Medicare is typically considered a single-payer system, okay? There's 16 million people that are supposed to be covered during the budget window. Who pays for the cost of expansion? The government does. The government will pay for new enrollees who are coming into the system from 2014 to 2016 at 100% of the cost. Now, I'm not sure where that money is coming from, but from 2014 to 2016, the government is going to cover 100% of the cost, and from 2016 to 2020, that's going to scale down to about 90 to 95% of the cost. So what the government basically has said, hey, guess what? To the states, we understand, and states, again, receive Medicaid matching funds from the government, and there's a whole formula for that. I'm not going to go into that because I just simply don't have the time. By the way, for those who are following, we're on page 1,000. So we are moving expeditiously. So if you look at what the government actually spends on Medicaid programs across the country, it's about 57% of the budget. It's the 5th largest budget item, just behind Social Security and Medicare. Okay? So Medicaid is a very, very expensive program. Now, there are people who are dual eligible. They have both Medicare and Medicaid, okay? And what we call Medi-Medi. Okay? So these folks typically have greater coverage than those folks who are just covered by Medicaid by itself. So the cost of it, now the post-Supreme Court decision, let me just say this really quick. When the Affordable Care Act actually came out, the states had to participate. It wasn't voluntary, you had to participate. If you didn't participate, the government was going to then, in theory, take away your existing Medicaid matching funds. So then the state said, hey, wait a minute, it's not fair. You're telling us to participate in the Affordable Care Act. We don't agree with some of the legislation. We don't really understand it, but yet we have to participate, and by 2014, we have to be ready to enroll people. So what they did is they took it to the Supreme Court and said, listen, wait a minute. Why are we being coerced into having to participate when we don't agree? This should be a state decision, not a federal government decision. So what they ended up doing is the Supreme Court actually sided with the states and said, listen, guess what? You don't have to participate. But the government also, in turn, cannot take away your existing Medicaid dollars as well. So they still have to fund the programs as they are, but in order for them to get extra money, they have to participate in the Affordable Care Act. So the states won that battle. Now, that's a huge problem for implementation purposes, because that's the primary mechanism that folks are supposed to come into the system is through Medicaid. So if you have states that are opting out, then where do those folks, millions of folks who are underinsured or uninsured, get care? That's the problem. They come to California, my state, to get care. That's what happens. Okay? Now, by the way, we have the largest uninsured populace in the entire United States. We have about 7 million people that are uninsured. And I'm going to give you the California experience on how we expect to insure those folks, because I think California is actually doing a good job about that. All right? So Medicare changes under the Affordable Care Act. Many of you know the closing of Part D donut hole in 2020. That's a good thing. Okay? No more are people going to have to pay outrageous, out-of-pocket, money for prescriptions any longer, or out-of-pocket, taking out-of-pocket, okay, I think I'm saying that wrong, out-of-pocket expenses to pay for prescription drugs. Beneficiaries who reach the coverage gap in 2010 will also receive a $250 rebate and 50% reductions on trade drugs. Now, this also came during the election cycle, so this was actually pretty interesting as well. And preventative services, there's no more cost sharing. Okay, so if you need preventative services like a mammography or PSA or anything like that, there's no co-payments or deductibles typically under the Affordable Care Act. So there are a lot of benefits to the Affordable Care Act. Would you agree? Closing of the Part D donut hole is significant. That will return about $6.1 billion to seniors over the course of a decade. That's pretty significant. Okay. Anybody know about IPAB? I'm going to explain it really quick. IPAB and MedPAC. MedPAC is the Medicare Payment Advisory Commission. Their job is to essentially look at the cost of administering the Medicare program every single year. So every single year they present to Congress a report and say, Congress, this is how much it costs to administer the Medicare program, and these are the cuts that we would be recommending. Unfortunately, Congress has largely ignored them for the last decade or so, and basically said we're not going to make any cuts because we won't be in office after that. So, so they don't really have any regulatory authority. What they do is they give reports. Now, the Independent Payment Advisory Board actually came out of the Affordable Care Act. It's a 15-member board which has to be selected by the Senate Majority Leader of the House and Senate. It also has to, the president also appoints folks to this board as well, and they need to be Senate confirmed. They have regulatory authority to usurp Congress. They can recommend cuts, draconian cuts, to Medicare that, if adopted by the Department of Health and Human Services, can be enacted without a vote in Congress. The only way that it can be overturned is through a supermajority in the Senate. Okay? So this is a significant, in my viewpoint, cost containment strategy. Let me just say this. How do you cut health care costs in America? Can you really cut health care costs without rationing care? You can't. We do ration care in this country. I know that's kind of an egregious comment to make, but the reality is we do ration care in this country. We ration care based on price. And I'd be more than happy to debate that with anyone, okay? We actually ration care in this country based on price. So really, in 2015, when these folks come online, there's really nothing for them to do because Medicare growth rates have not exceeded economic growth rates plus an additional 1% per year. So there's nothing really for them to do from 2015 to 2016, but they will be making some recommendations which will be looked at significantly. And by the way, IPAB, you heard the term death panels, right? It was referring to this group. Now let me just say this, there is something haven't seen in a long time. There's bipartisan support in Congress for repealing this portion of the legislation. Republicans and Democrats do not want the Independent Payment Advisory Board at all. They think it's absolutely going to lead to draconian cuts to Medicare, cuts to reimbursements, cuts to access. So it's going to be counterintuitive to actually bring them online, according to many folks in both the House and Senate. How will the recommendations made by IPAC impact the healthcare industry? Again, we talked about before, there's going to be some draconian cuts, but here's their mandate. They can't ration care. Any of their recommendations can't raise revenues, and they can't increase Medicare beneficiary payments or cost sharing or deductible or co-payments. The reality is, so then where do you make the cuts? Where do the cuts come from? Reimbursements. You guys have heard of the doc fix, right? Okay? It comes on the side of reimbursement. So if I can't raise premiums and I can't, push that onto the consumers of healthcare, then where does it come from? It comes from the healthcare delivery folks, right? On the side of reimbursement. Now, let me talk about certified healthcare exchanges really quick because I think this is really important. Because certified healthcare exchanges are the pivotal point to healthcare reform. Okay, it's the mechanism in which you apply for a federal subsidy, in which you apply for eligibility in the Medicaid program. So it's a marketplaces where insurers compete for customers. It's a partnership exchange. Now, every single exchange has to connect to at least 7 federal regulatory bodies in the government because there's so much information sharing that has to be done. A healthcare exchange is simply not separate, but it's also private. Okay, so you can have both a private and a public healthcare exchange. Now, healthcare exchanges also really are certified, qualified healthcare plans. So they offer a menu of options. They have many different providers. They offer an array of benefits. They're typically tiered. So a healthcare exchange will offer tiered benefits in terms of silver, platinum, bronze, and gold plans. We're going to talk about that in a moment. And how many people are slated to go through a healthcare exchange to receive a federal subsidy and also to receive eligibility to Medicaid or purchase an insurance is going to be millions. Now, here's the interesting thing about this. Are states required to set up exchanges? Absolutely. States are required to set up a healthcare exchange. What happens if they don't? The government will come and set up one for you. So you don't have a choice. You have to set up an exchange. Okay? Now, there's currently 17 states that are in the process of setting up an exchange. 33 states have opted out. Now, that's significant because the enrollment period is October 1st of 2013. So 33 states have basically said to the government, guess what, we're not going to set up an exchange at all. 17 states have. So the 17 states, they get the federal subsidies, they get the eligibility to get into Medicaid, but the other 33 states, the people that are extremely poor, how do they get access to care? Well, really, how do they get access to coverage? Okay? So that's significant. Okay? Now, the government has basically said also there are public and private grants available because setting up a healthcare exchange is a fairly arduous task. It's not easy to do, and it's not a new concept. Before or pre-healthcare reform, we had healthcare exchanges which were set up in Utah and New York. So we have a template to follow, which is what the government, I believe, has been doing. So there are public and private grants, but $100 million of grants have been returned back by states that have conservative legislators, typically Republicans. Okay? So what if I like my current health care insurance? Can I keep it? Remember, the administration came out and said, well, listen, if you don't like what we're offering, you can keep your own health care insurance. You don't have to buy anything that that we're proposing. If you like it, this is really for the uninsured. These are the people who don't have access to health care coverage. So this is for them. You don't need to participate if you don't want to. So let's see what it says here. So this is something from a McKinsey study, which is a big research firm and think tank. And they surveyed employers, and 30% of all employers are going to dump their employees onto the system when the Affordable Care Act comes live in 2014. So they're getting out of the health insurance game completely. We're tired of paying escalating premiums that have been going like this for the last decade. So we're going to put our employees onto the system and let them go purchase health care, and we're okay with paying the penalty. Because it's $3,000 if they get it through a health care exchange that I get penalized per employee versus me having to pay $10,000 or $11,000 for their health care coverage for the year. But what happens, so who pays for that? The taxpayer. Okay? 7 million people will lose their coverage under the Affordable Care Act. Again, this is not my opinion, this is fact. Okay? 7 million people will actually lose it under the Affordable Care Act, but they will be able to find insurance, typically in a health care exchange, if they meet certain federal poverty. Huh? That's the question. Okay. Okay, so she asked a very good question. So these folks who are going to be dumped on this system, are they going to find affordable coverage? Are they going to find affordable coverage? No. Are you sure? If they go to California, right? Okay. That's the default answer. Okay? Is everybody understanding me? Am I going too fast? Am I clear, articulate? Can you guys understand what I'm saying? Yes. Okay, that's important. Make sure you write that on your evaluations. All right. All right, so let's go ahead and continue. All right, so let's look at physician sentiment. Because physician sentiment is really the pulse on the industry, right? If the physicians are unhappy, then that means something really is wrong with the system, right? So let's see what the physicians are saying about healthcare reform, because obviously people say they're the advocates for the patient. So Deloitte research think tank actually surveyed 501 physicians. 60% expect the quality of health care to decline in the country. 70% believe that medicine is no longer an attractive option to the best and brightest, and increased wait times for primary care appointments. And they also, in that study, there's also going to be more utilization of the emergency room. So for those folks who are working in emergency room, your patient volume is going to increase dramatically in 2014. Okay? As a consequence of health care reform, physicians will opt for early retirement. This was in that study. Assume non-clinical roles and limit access to their clinics. Now, why is that? Because Medicaid pays 66% for the same service reimbursed by Medicare at 100%. Does that make sense? So every service that you do on Medicaid, you're paid at 66% of the reimbursement you would get if you perform that same service typically on a Medicare beneficiary. Okay? Now, let me just say this about Medicaid adoption really quick. How many folks take on Medicaid patients? New ones. Very few. Matter of fact, which state has the lowest adoption of Medicaid? Washington, this great state. Okay? This is where healthcare reform originated. It's 30%. Actually, California does see Medicaid patients at a lot higher on the scale than I think Washington does. Okay? So what about implementation? Okay? Now, it's important for us to really kind of look at this very critically, because remember, if 33 states have opted out, how are you going to implement healthcare reform if there's no healthcare exchange? How are they going to determine eligibility and federal subsidies? Okay? So here's what Matt Baucus, which was the architect of healthcare reform, said about the Affordable Care Act. He said recently that it's a train wreck. The implementation process looks like a train wreck. Now, he's a Democrat, so I'm going to make sure I throw that out there. Senator Reid also said, man, this looks like it's going to be a train wreck unless we can throw some money at this. Unless we can throw some money at this, we're not really going to get this thing implemented. Senator Jay Rockefeller, also another Democrat, said, this is the most complex piece of legislation that we've ever passed in Congress. It's beyond comprehension. End quote. Okay, don't record that. The United Food and Commercial Workers International Union, which has been a supporter of the Obama administration and actually helped to support his reelection, have basically taken a step back and said, hey, we're concerned about the implementation as well. And then, of course, the United Union of Roofers, Waterproofers, and Allied Workers released a statement recently calling for a repeal of the Affordable Care Act because people are concerned about the implementation. We don't have health care exchanges. There's not enough money to go around and implement. There's all this political upheaval in the states. We're not going to get this thing implemented by 2014. Folks are not going to have access to coverage. We're not going to have care coordination. There's going to be some significant issues. Let me go back here. So under the Affordable Care Act, now this is interesting. Now someone asked the question about will premiums be affordable? Will coverage be affordable? So here it is. Under the Affordable Care Act, medical claim costs are expected to increase by 32%. According to individuals, a new study of the Society of Actuarials. Okay? Does everyone know what an actuarial is? An actuarial is really a statistician that uses economic theory and statistics to actually project healthcare costs. They're used by every single healthcare organization, pension plans, you name it. They're really, really smart people, and for those folks who really are interested in going to actuarial science, there's a good job market for them. But basically, 32% increase in premiums. Okay? Medical claims in California are slated to rise by 62% in 2017. Is that significant? Okay? The IRS estimates that the cost of a medical plan, a cheap plan, the bronze plan, will cost a family of four $20,000 under the Affordable Care Act. And then we also have political brinkmanship, right? We can't get anything done, can't get any traction in Congress. There's arguing, bickering, contention. You know, there's issues going on in the states. So there's a problem, okay? So there's a national campaign, by the way, to try to, and I want to say this before I get to the national campaign. There was a survey that was recently done. 50% of Americans don't even know that we passed health care reform. They still think we're debating it. They have no idea that we've actually passed health care reform. They think we're actually in the debate phase of it. And they're looking to see what legislation is going to come out of that. We've actually passed it in 2010. Okay? So there's a national campaign of a coalition of healthcare provider and advocates and also community leaders that are actually going out to the public and saying, guess what? We just passed healthcare reform, and this is how you can enroll. There's an opportunity for you to get coverage. And most Americans say, well, no, we haven't passed it. You know, we have. So Enroll America that's their job along with other community groups to actually go out there. And the Department of Health and Human Services is also soliciting other members from the community to help spread the message about healthcare reform. Now, the enrollment application was 21 pages when it first came out. 21 pages of information you would have to write down and answer all these inquiries before you would find out if you were eligible for Medicaid and a subsequent federal subsidy. Now, that proved to be pretty arduous and difficult, right? Because 21 pages of information, you almost need an accountant to fill it out. Okay, so now they've consolidated. Now it's only 3 pages, and I'm pretty happy about that. Now, again, the enrollment period is October 1st, 2013. All right, we're on page 3,500. We're almost done. All right, so is it true that the Affordable Care Act's implementation will be a train wreck and will cost so? I just provided you information. That's not a hyperbole on my part. This is information. This is data that I've data mined and pulled into a PowerPoint presentation. So now I've presented you the information. You're going to see a 32% increase in premiums. Medical claims are going to go up across the board. There's not going to be a whole bunch of healthcare exchanges that's once thought by 2014 to bring people into the system. So it seems to be, to me, there's going to be a train wreck. Would you agree? No. So let's look at the California experience. Okay? Let's look at the California experience because maybe I'm wrong. It's rare, okay, but maybe I'm wrong. All right? So let's look at the California experience, okay? So what is a federal subsidy? A federal subsidy is essentially a tax credit, okay? It's a credit against your future tax liabilities, okay? So essentially, you're going to get a tax credit if you qualify based on a certain federal poverty level. So if you're between 100% of the federal poverty level and 400% of the federal poverty level, you can actually get a tax credit. And 400% of the federal poverty level for a family of 4 could be $95,000 a year, and you could get a tax credit to purchase insurance. Did you know that? So let's kind of look at that a little bit more critically. 18 to 21 million people will be eligible for a tax credit. And Covered California Exchange is one of the better exchanges that have just recently been implemented. It has agents that you can call. It has a great Q&A session. It has a menu of options. It lists benefits, pricing. Everything you would ever want to know about purchasing a healthcare insurance could be done through Covered California Exchange. Very, very interesting organization that put that up. So here's the income versus premium limit. So if you're up to 33%, now let me make sure I make this very clear. If you're up to 133% of the federal poverty level, you cannot pay more than 2% of your income towards purchasing health insurance. Does that make sense? If you go down to 400% of the federal poverty level, you cannot spend more than 9.5% of your income to purchase health insurance. Does that make sense? Okay? So that's critically important. So let me give you an example of that. Okay? So here's a household income. You're a family of 4. You're about 150% of the federal poverty level. You make $31,000 a year. The yearly cost of health care insurance without a government subsidy would be around $12,300. The yearly federal government subsidy would be $11,000. You wouldn't receive it, but the insurance company would receive it on your behalf. Because the tax credits are advanceable and refundable. Okay? And your monthly cost would only be $1,200 over the year. You would pay $100 a month. Tell me where you can get an insurance rate like that on the individual market. You can't. Okay, let's look at example number 2. Family of 4, you make $88,000 and now you're 400% of the federal poverty level. Your cost to date for insurance would be $12,300. You'd receive a subsidy of $3,900. And you would only be responsible for $700 per month for a family of 4. That's pretty, and by the way, you're going to get great coverage with that. You're not going to get catastrophic coverage. You're going to get great coverage for that. Okay? Depending on which plan, if it's the silver plan or the bronze plan or the gold plan or the platinum plan, there's different tiered plans. Okay? I'm going to just get past this example just for time's sake. Now, there's more advantages. Okay? No longer are there any more costs for medical underwriting by the insurance companies. They have reduced marketing expenses, right, because they can market through a healthcare exchange, and they limit profits to only 2 to 3% of participating qualified health plans. That's a plus. We should be clapping for that, right? Matter of fact, if you make at least 5%, you're actually doing good if you're health insured. So limiting to 2 to 3% as a qualified healthcare plan participating in healthcare insurance is actually pretty good. So it's no longer about profit, it's actually about taking care of patients. And that's what I like. But is there a disincentive to using the healthcare exchange? There is. If you make more or if your family size changes, you now fall out of the federal poverty limit and you are no longer eligible for the subsidy. So if you make more money, now you're back on the individual market, now having to pay these escalated rates again for insurance. So you almost have to stay within the federal poverty level in order to make sure that you get this subsidy. Now, the subsidy is adjusted based upon the CPI for inflation. Now, the problem with using the CPI as a metric is the CPI doesn't factor in food and energy, which, you know, we all eat and we all use energy, okay? So it's hard to factor in inflation if you don't factor in those two components, okay? We're almost done here. How will the Affordable Care Act expand primary care? Many of you already know this, you're educators. There's loan repayment programs, there's scholarships, there's funding for CMS for residency slots in primary care. And also from 2011 to 2015, there will be a 10% bonus if your Medicare charges for office visits make up at least 60% of the overall Medicare charges. Now, will you get that bonus? No, your physician will. Okay? So you get a 10% bonus for that, okay? And Medicare payment rate changes. The government is actually looking at the skewed reimbursement system, which has essentially been skewed to specialists and trying to skew it the other way to primary care. And that is a great idea because how do you increase the primary care workforce? We've been seeing a precipitous decline in the primary care workforce for decades. Why? Because reimbursement is low, there's high dissatisfaction, Medicaid patients are very difficult to take care of. They come in with chronic conditions, and people are getting out of, and plus the indebtedness, right, causes folks to go into specialty care. Now the government is looking at payment models to actually reimburse higher for primary care services that are rendered, okay? And they're establishing a new center of Medicaid and Medicare for that very purpose to look at innovation and demonstration projects that are going to improve payment models, improve coordination of care with the intention of developing payment policy that favor primary care. So where the opportunity is, ladies and gentlemen, is in primary care, not specialty care moving forward. And I say that as a specialty PA. Okay, I'm going to have to start looking at maybe repatriating back into primary care at some point. Expanding the term of what constitutes PCP. Now, let me just say this really quick. California, other than developing a healthcare exchange, are actually trying to redefine what constitutes a PCP. Right? Before it was just a physician. Now they've incorporated PAs, and now they're looking at incorporating optometrists to be primary care providers because we have 5 million members or 5 million uninsured folks, and we have not the healthcare workforce to take care of them. It's estimated by the Physician Assistant Committee by 2015 we need 4,000 additional PAs to take care of the folks coming into the system just to meet the requisite requirement of the Affordable Care Act. The problem with that is we're losing as many PAs as we're graduating in the state. They're going to Texas, North Carolina, they're going elsewhere. So who's picking up the slack? The nurse practitioners are. They're picking up the slack, and they're also pushing forward for more autonomy as well, because in a crisis, you can get things done, okay? I guess that goes to Raw Emanuel that says don't allow a crisis to go to waste or something like that. Many of you folks know about that. So here's something that, and I'm going to get on a soapbox for a minute. NPs are looking at independent practice in primary care clinics. Let me ask you folks a question. What is the technical skill level between a practicing PA who's been practicing for 10 years and a nurse practitioner who's been practicing for 10 years? Is it the same? So why are they fighting for an autonomous practice and we're okay with the status quo of being dependent practitioners? Okay, I just want to say that again. We're okay with being relegated to being dependent practitioners. I'm saying this for primary care because in specialty care, this doesn't work. But in primary care, where you have nurse practitioners and you have an IOM report that says that the care that they provide is just as good as any doc in primary care, and the technical skill level is the same between a PA and a nurse practitioners, why are we happy with being dependent practitioners when there's a huge influx of people coming in to the system who need primary care services because of the Affordable Care Act? Food for thought. Okay? It's more of a political distinction. Right. 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 Absolutely. Right. And I wonder if you can still have that team approach, because even though nurse practitioners run independent clinics, they still have a team approach to medicine. Sometimes they have it through a collaborative bargaining agreement, but they still have, not a collective, it's a collective. Collective. Yeah, exactly. All right, we're almost done. And so how does the government plan to pay for healthcare reform? We're almost done, folks. There's going to be cuts. There's going to be a 2.3% excise tax on medical device manufacturers, 7.5%. Now, let me just say this. It used to be that you can deduct your healthcare cost. If your healthcare cost exceeded 7.5% of your adjusted gross income, now it has to be 10%. Okay? There's going to be a 40% excise tax on Cadillac plans, which are high-end plans, and there's going to be a tax on earned and unearned income to pay for this. Okay? Medicare home and health care payments will be cut by $40 billion. There will be cuts to hospital payments in the tune of $22 billion. Employer and individual penalties for noncompliance, and the sequestration cuts. Let me just say this about the sequestration. Remember the sequestration cuts? They weren't supposed to happen. The sequestration cuts are essentially $109 billion of indiscriminate cuts across the board. Okay? Now, $50 billion of that was for the Department of Defense, and the other $50 billion was for social programs which favor the Democrats. So they were supposed to bring both Republicans and Democrats to the table so that it wouldn't happen. It happened. Okay? So now there's a 2% across-the-board cut for Medicare because of the sequestration cuts. Now that's significant, too, as well. And we have concluded. Thank you for your time. Any questions?
Come to the mic. Come to the mic, please. It's right up in the aisle.
So,
Any questions? Yes.
so how is a 40% tax on a Cadillac plan not punitive?
I'm sorry, say again?
Yeah, mine's not. So how is a 40% tax on a Cadillac plan not punitive?
It is punitive.
And so,
Absolutely.
how is the revenue generation that you just showed us not evidence that it is indeed a train wreck? Because
Right.
it is a tax. It is a tax that's set across. It's
Right.
a disincentive, and
Sure. Sure.
we could talk for an hour on how
Absolutely.
this is going to
Yeah.
play out.
Well-
I'm part of a medical home, and so we
Okay, the
try to do
patient-centered
things
medical home.
that are very, very efficient, and we decrease ER visits and hospitalizations and blah,
Yeah.
blah, blah,
Yeah.
right? But in order for a medical home to work, you need to not look at any numbers for 5 years.
Right. Right.
We're not going to be able to look at any numbers with this for probably 15 to 20 years.
Absolutely.
And then maybe. So
Right.
is it sustainable for that 2
Well,
decades?
well, see, that's the question. The question is any of this sustainable? And the reality is, even though we looked at California as an example, because California is essentially the 8th largest economy in the world, and it's a huge state that can really be considered a country. So if you look at that as a template, if California can do it, the question is, can other states do it? And the reality is other states are not moving with the same tenacity and with the same aggressiveness, if you will, that California is moving. So that is proving to be an issue. But the reality is all of this is a big tax if you really look at it, because you have to have increased revenues in order to pay for it.
What's the deductible on the bottom level plan for California?
What's the deductible? I don't know yet. They were released on Thursday. So the information I presented, the prices just came out on Thursday. So I'm still trying to tease that out. Still trying to tease that out. It could be punitive as well. Yeah.
Poverty line family.
Yeah. Yeah.
So speaking to your question, the question that you raised about PAs in primary care relative to nurses,
Yeah.
I'm going to pose a rhetorical question.
Sure.
Virtually all states have maximum numbers of PAs that can be supervised by any particular doctor.
Right, right.
But I don't think that there are any regulations as to how many doctors any one PA can have as a supervising doc.
Yeah. California has that.
They do have
Yes,
that
4
limit.
to 1.
What's that?
4 to 1.
So a PA could only have 4 supervising docs
Oh, no, I'm sorry. No, actually, no, they can, 4 PAs per doc.
per doc, but
Yeah.
not the other way
No,
around.
not the other way around, no.
So a entrepreneurial PA or group of PAs could, for example, open a primary care practice
Yeah.
and contract with a number of physicians
Right.
in specialty organizations and have them be their whole panel of supervising docs. That would allow PAs to practice as primary care providers and be primary care medical home providers.
Absolutely. And actually, that kind of goes to the concept of accountable care organization, right? The ACOs.
Right.
So there is an opportunity to where you can actually consolidate practices, bring in more providers, and you can actually, an ACO actually takes care of Medicare beneficiaries. You have to have a minimum of 5,000 Medicare beneficiaries, address their needs, care coordination,
Right.
Quality improvement, keep them healthy, keep them out of the hospital for a minimum of 3 years, really. So there is some opportunity of forming those types of groups. We have those in California now. They're not ACOs, but they're independent practice run by PAs, but they subcontract with physicians for supervision.
Yeah.
Any other questions? Did everyone understand this? Does this make sense?
Yeah.
Well, thank you. Thank you. Fill out your eval.
Can you talk about Vermont, the Vermont model?
And thank you for referring to us as a state.